So thanks, first of all, for having me here. I'm not part of the Baystate family, although I feel as though I'm certainly a distant cousin. I know some of you, having worked on a couple of initiatives in the past, and it's really a pleasure to be here. So I'm a physical therapist. I'm a professor of physical therapy in the DPT program at Springfield College. My area of clinical specialization is neurology, and that has, an obvious overlap, especially when we talk about, well, not just actually progressive, but also acquired conditions with, adult and older adult populations. And I'm going to kick things off, and Iskra will chime in just a little bit later. So, much of what I could do by way of introduction has actually come up here and there already this morning. So, with respect to objectives, falls have come up. Some of the intrinsic and extrinsic fall risk factors have come up. The burden and impact of falls has come up. So I'm going to spend very little time actually on the.
Okay, we got it back.
Looking good, sounding good.
Good. Okay. So really what I want to do is focus on what we can do about these things from a physical therapy perspective. All right. And now I've got to find my advance now that it's screen shared. So again, I apologize. Give me one moment.
If you make sure you are on PowerPoint, you should just be able to advance with
Yep, I got it. So that should have advanced for you. Right. So, you know what balance is, right? Balance is really complex. Balance is really a multi-system function. The musculoskeletal system plays a role. The neurosomatosensory system plays a role. The neuromuscular system plays a role. Lots of overlap among those three systems. Cognition, attention, the integumentary system, the cardiovascular pulmonary systems, they all in one way or another make a contribution to balance. When all of these systems are working well, we don't even have to think about maintaining control of our center of mass within our base of support, or we don't have to think about making a really quick shift in base of support when our center of mass starts to exceed what we refer to as limits of stability, right? We reach a little too far, we lean a little too far, we trip on something. And all of a sudden our torso is moving beyond the balance point of our feet. And we have to reach out with a hand, or we take a quick step to do a correction, right? And when all of the systems are contributing as they should, we don't even have to think about how that happens. But as we age, there are some natural changes that happen with aging that interfere with the rapid automatic functioning of those systems. And as we age, we're more likely to acquire other either discrete or chronic conditions that further affect those systems and interfere with their functioning, making balance even worse. And obviously when balance fails, right, we hit things that we don't want to hit, most often the ground or the floor, and sometimes something else on the way down, right, which is why falls, the result of balance discontrol, are really so significant because of the risks that they bring, as you all know, for injury, sometimes minor, sometimes fairly grave. So our best preventive efforts are obviously really important. And, as I teach my students and talk to my patients, I never make the case that the objective is to avoid loss of balance altogether, because that's not reasonable for most of us in our daily lives. We all lose our balance on occasion. We want to minimize losses of balance, but just as importantly is our ability to regain our balance on those occasions that in fact we lose it. And lots of people lose it. So a third of adults age 65 plus fall each year. As we get older, that proportion gets higher. So a full half of people who are aged 80 or greater are falling every year. Falls cause injury, some of them again minor, some of them fairly significant, and falls can be either primarily or secondarily a cause actually of death. The cost is high. I don't need to review the numbers. The cost is really high, right? Hospitalizations, rehabilitation, post-fall has a tremendous cost burden. And, I think we're doing better as far as falls risk assessment goes. Across the spectrum of care providers who work with adults who are at risk for falls. Even though we're doing better, I think we're not doing well enough, because I think in large part our response to falls, the likelihood of falls is still more reactive than proactive. And so I think that we still have work to do on shifting a system toward a more proactive approach to preventing falls to begin with, because, you know, this truly is a case where a good offense is the best defense. It's best to prevent falls because it's much harder to treat the consequences of falls. So risk factors, there are lots of them. Some of them people have talked about much more elegantly and with more depth than I can this morning, primarily with respect to you know, some health conditions, as well as pharmaceutical management. Polypharmacy is a major risk factor for falls. And you heard from folks this morning about some of the reasons that that's true. You know, unwanted effects, cardiovascular dysfunction that leads to orthostasis, weakness, attentional issues, right? Cognitive changes as a result of medications all increases one's risk for falls. But here on this slide, right, we have advanced age. Now, aging in and of itself, as we know, is not a pathologic condition. Aging does, however, bring with it changes in sensory and muscular systems that are responsible for managing our postural control systems. So as we age, the sensitivity of our touch, of our pressure, of our joint position sense, of our visual systems, of our vestibular systems, right, they all degrade just a little bit. And as that sensitivity degrades, we have a little more difficulty. We're a little slower in knowing where we are, how we're moving, and how we might have to make adjustments and corrections as we move through our environments. Those things are compounded, and this jumps down to the bottom of the slide, by chronic conditions, right? When people have things like Parkinson's or diabetes or osteoarthritis, or have acquired a neurologic condition other than Parkinson's, like a stroke or a traumatic injury, right? There may be pronounced changes in sensory and neuromuscular function that, again, lead to degradation in the postural control system. Once someone has fallen, right, they're at big risk for future falls, partly because the thing that caused the first fall, or the things that caused the first fall, are not likely to go away, or at least not completely, even with intervention. And the second is that falling once often makes people fearful. And fear itself doesn't cause someone to fall often. Fear itself makes people limit their activities. And when people limit their activities, the things that were producing the risks for falls to begin with are likely to be exacerbated. So falls risk actually in some people has this cyclical nature to it, right? A first fall exacerbates the conditions that cause the fall to begin with, unless we can interrupt the cycle. So here's how we can do it. Someone mentioned earlier steady. I'm going to turn it over actually at this point to Izckra, who's going to talk through the steady and a couple of things that follow. This is a busy slide. I just want to point out that I believe in your screen view, you have an option to magnify portions of your screen. So if you're having trouble seeing this, you can go ahead and magnify it to a place that's comfortable for you. Right? Izckra. You are muted.
Can you hear me now? Okay, guys, I'm Izckra Speight. I'm a community health worker, Baystate Health Coach program. And so now we have the algorithm. What do we do now when we have a patient coming into our office and asking, we are going to ask the questions, right? How you fall in the past year? How many times were you injured? Are you unsteady when walking, or are you afraid of falling? When we have these questions, then we have to decide what we're doing with a patient. So we are going to classify the recommendations for low risk, moderate risk, and high risk. You can see them at the right side of the screen. I don't know if you can point at them, Regina. Mm-hmm. So after the questions on that tab, you have the questions. If the questions are negative, you're going to treat the patient as a low risk. And you're going to recommend education. You're going to provide education to the patient. You're going to provide vitamin D or calcium if appropriate. And then you're going to refer the patient to a strength and balance exercise or a fall prevention program. If the questions that you're doing are positive, if they are yes, then you're going to do testing. You're going to do that time, get up and go. You can do that 30 seconds chair stand or the 4-stage balance. If this testing is negative, then you go back and treat the patient as a low risk, and you recommend the things that I already mentioned. If the testing is positive, then you're gonna go and ask, it's 0 falls, 1 fall, 2 falls. If the patient didn't have any falls, then you're gonna provide recommendations as a moderate risk. The moderate risk includes what I already mentioned for the low risk, but you're gonna add to review and modify medications, and you're gonna refer the patient to physical therapy just to improve the gait, the strength, and balance. So now, what if the patient had 1 fall and no injury? Then you're gonna do the same. You're gonna provide recommendations for the patient as a moderate risk. And what about the patient that fell and had an injury? Then we're gonna go to the bottom of the slide, and we're gonna do a multifactorial risk assessment, which includes revising the brochure Stay Independent, which is part of the STEADY program. You're gonna go through the falls history, and then you're gonna do a physical exam. In this exam, you're gonna include postural hypotension, make sure that he's not having problems with that, medication review, cognitive screening, feed, vision check if they need glasses or stuff like that, and mobility aids. Then after that assessment, you're gonna do an intervention for patients with high risk. In these interventions, you include what you already did with the moderate risk patients. Like you're gonna educate, you're gonna provide medication, vitamin D, but you're also gonna monitor the hypotension. You're gonna address the food problems and the vision problems. So after you did all this, you're gonna try to follow up with a patient 30 days later, and just to see where he is at, see if there is any reduction on behaviors, check if there's barriers to adherence, like if the patient is compliant or not. And then you can maybe transition into maintenance with just an exercise program. Yeah, Regina, do you want to add anything?
No, I may come back to a point later, but not for now.
Just want to keep an eye on time, guys. We're cutting into our lunch a little bit, so just a heads up on time. Thank you.
Okay, so these I'll just, I won't say anything about these. Others, again, have really, covered these quite thoroughly already this morning. The only thing that didn't come up probably is foot deformities and footwear, especially folks with arthritic changes who have trouble getting into shoes comfortably. A referral to a podorthist, someone who can really help, not with custom shoes, but with therapeutic shoes, may be helpful. And, I think the biggest thing is that we know that exercise and physical activity really works, right? So obviously, as a physical therapist, I have a bias toward physical therapist intervention. And I think that the most effective place to intervene is right here, right before people start falling. We need to make sure that they're maintaining a level of physical activity that helps to mitigate the severity and the progression, right, of chronic conditions that produce the factors that put people at risk for falls. So I think early referral to folks who can really help with physical activity training, from my perspective, are some of the most important things that can happen. It doesn't matter so much what people do as it matters that they do. So if they like to swim, they can swim. If they like to walk, they can walk. If they like to cycle, they can cycle. If they like to dance, they can dance. What matters is consistency, intensity, duration, right? The dose has to be high enough, as well as long-term commitment, right? And that's where we need to come in as, as educators, as coaches, and also as physical therapists, provide the targeted intervention that folks need when they have problems that require more of a specialized approach than a non-assisted exercise plan. So I think in the interest of time, Izckra, if this is okay with you, let's skip over the assistive devices. A word about home safety. We need to be talking to folks about how their homes are set up with respect to stuff that they could trip on, that they could slip on, that they have to walk around, and conditions, especially for movement at night, especially as sensory systems degrade. Visual substitution becomes really important. But, if anything, for me is the take home, it's that there's a really robust literature about, with appropriate dosing, the effectiveness of balance, strength, and gait training. And consistent physical activity. Even for people who are quite elderly, with quite a number of physical conditions, we can still do dosing and activity prescriptions safely.